Thank you. We'll be moving on now, going more national, and we have Dr. Eric Perakslis giving us the next presentation titled Disparities from the Field, Trying to Eliminate Socioeconomic Disparities in COVID-19 Testing Data. Eric has a long list of titles, would take me his whole time to list them all. I'm glad to say that when asked which title to introduce him by, he chose the Duke Rubenstein Fellow. He is also a former Chief Information Officer at the U.S. Food and Drug Administration. Eric?
Yes, hi, can you hear me okay?
Yes.
Okay, great. Hey, everybody. Greetings from southeast Utah, just outside the tribal lands of the Navajo Nation. So I'm working on a project that's kind of been in stealth mode to help getting better data from really low resource areas. You know, some of the things we've heard today about some of the great things that North Carolina has done to kind of improve state reporting and improve data availability, and then actually walk that data back into those communities to help those communities. What's tough in some certain parts of the country is that you just don't know when things are being underreported. So we know that ethnicity, race, and a lot of these things have been traditionally underreported across the healthcare spectrum, and they're certainly being underreported with COVID. So here's just a few things, you know, and it's really interesting, but when you think about data, you know, nothing gets by the weakest link in the chain. And so if that is a field hospital, if that's a parking lot, if that's a clinic, then that's the rate limiting step. And yes, people are still using fax machines. We know that COVID is affecting disparities. And of course, the Navajo Nation is one of the most hard hit communities in the country. And so working on this project with the World Economic Forum, as well as the Council of State and Territorial Epidemiologists, to try to figure out a way to improve point of care testing and reporting from remote and low resource sites. So basically, if you think about, for example, FEMA bought 16 or 1700 Abbott ID Now machines and distributed them. For the ones that went to hospitals, they used their EHR. You know, for the ones that went to CVS, CVS has an EHR, they report through that. For the ones that went to remote sites like prisons and places like that, they didn't really have a reporting solution other than phone. And so working with this group, we got some equipment. I actually wrote some mobile apps and have been traveling, going site to site with a methodology that kind of looks like this. So normally we can bring a site up in about 2 days, go to the site, find out what the needs are, study their workflow, modify the app, get them equipment, get them reporting, get them up on the system, make sure it's flowing through to the Department of Health in Utah, and then get on to the next site. So far I've been in rural clinics. I'm at another rural clinic over the weekend, and then I think I'm in a prison Monday and Tuesday. So just kind of moving through and getting this data flowing, and making sure that that the right things are actually being reported. You know, it's interesting. One of the clinics I was in, for example, they're doing COVID testing on all their pre-op, which of course that makes sense. But when they put the order in for the COVID testing, nothing really comes down from the EHR other than what the lab needs. So they don't have ethnicity data. They don't have those pieces of information. So then of course they're not reporting that to the state. And so, you know, amplify this workflow over lots of times. And, you know, then we go back to the health authority and really help them get it plugged in. So far, so good, meaning that the people are excited to get the technology. The people are excited to do better testing. You know, to share one anecdote that occurred to me, I was spending the morning with one woman who was running all the tests that day on their new machine that had just been validated. And she is of mixed Native American and Caucasian race. And I said, what do you think you're seeing here? And she basically said, if the name sounds white, I haven't seen a positive test yet. You know, and she wasn't saying anything inappropriate there. She was just anecdotally saying that, you know, she could almost tell from the name that came down whether or not, you know, what the risk of that person was. So this is a generic workflow and how we're doing it. It's a lot of fun for what it is, and it's helping a lot so far. So I will keep you posted. And of course, we've been doing this in stealth mode, but I do expect that the CSTE, the World Economic Forum, and Duke will be talking about this pretty soon. So my 5 slides, any questions?
Thank you very much, Eric. One question, I know you've done infection tracing work in Africa, and any comments, what we can learn from Africa, and then differences and similarities of what you see with COVID versus the infection tracing you've been involved in your work in Africa.
I think the big things that strike me is, one, there's a lot of similarities to 2014, 2015 Ebola with this, and I think a lot of other experts and veterans of that work say the same thing. I think what is interesting and what hopefully you're going to hear today is what seems to be the most effective thing is a mixture of top-down and bottom-up activities, meaning that really great work at the state has to be met, somewhere in the middle by really great grassroots work to get things done. So what can be done in the local area to get things done in a meeting in the state? When it's all top down, you could have the best reporting in the world, but if people aren't uploading the data, it's not mattering, right? It's not getting into the metrics. And they're only doing that if they have the resources to do it. So I think there's a lot of that. The only other thing I would say here that's different is that I think what we're seeing is what we should expect to see based on the things that we've done. So for example, we talk about ethnicity and race, but the socioeconomics of low-wage workers that don't have white-collar jobs that allow them to safely work from their computer in their living room, and these people are out in the Tyson meatpacking plants and stuff like that, we're seeing this large socioeconomic surge of cases that's related to low-paying jobs, which bring other risk factors. So I do think we have to look across traditional measures of disparities, economics as well as ethnicity and stuff like that. And the good news is we can target and try to work in those areas. The bad news is there's a lot of policy that we don't have yet. The only other thing I'll say is in Africa, the WHO had a really, really primary role. In some ways, if I could be so blunt, in 2014, 2015, the WHO played the role that everybody hoped the CDC would be playing right now, really coordinating, really issuing standards, everything from training to reporting and stuff like that. And I think without that overriding guidance from above, I think we're going to be a little helter-skelter.
And one other quick question, thank you. Is your app currently available for North Carolina testing efforts in underserved or those areas?
Yeah, if you're bringing up sites and they're using spreadsheets and telephone, absolutely. So just so you know that the Council of State and Territorial Epidemiologists issued an RFP looking for sites to all states, and they've re-upped it. So we're starting with the states that volunteered first, but if this would be helpful in North Carolina, that would be awesome.
Okay, wonderful. Thank you very much, Eric.